John Berdal is going to talk on management of suboptimal refractive outcomes.
He's going to give us his email address, and we're just going to send them all to him.
Yeah, thank you. That's exciting. So we're going to talk.
And actually, John,
Yeah.
you look really good. You've got a tie on and a suit. I just want to, point that out.
Whenever you're chairing, I'm dressing up. Okay, so we're going to talk about suboptimal outcomes, especially as it comes to astigmatism after cataract surgery. Here's my financial disclosures. Astigmatism fix is probably the pertinent one, which is really mostly a negative financial disclosure because it's a free website that I pay to keep running. So now we talked a lot about how do we make these people happy, how do we avoid them being unhappy, and now we're going to talk about fixing them when they come in and they are unhappy. And here's a patient of mine that is particularly unhappy with me, and she deserves to be unhappy with me. It's 1 week out from cataract surgery with a T9 toric lens. Her uncorrected vision is 20/70, and her refraction is minus 1.75 plus 350 axis 92. So she has every right to be disappointed in me after her cataract surgery. So I got 5 options really for this patient. Wear a pair of glasses, that would certainly continue her unhappiness with me. LASIK PRK, an IOL exchange, a limbal relaxing incision, or rotate the IOL. So how do we figure out how we get this patient and redeem ourselves? When you look at what astigmatism looks like from the patient perspective, this is what 30 degrees of a T9 toric lens being off axis looks like. Okay, so you can see why that'd be a frustrating way to go through existence. Now, high-powered toric lenses aren't as forgiving as low-powered toric lenses. Why? Because for every degree that you're off, you lose 3% of the effectivity of a toric lens. And so if you're off by 10 degrees, you lose about 35% of the effectivity of the toric lens. If you have a T3, that's only 0.36 diopters. That's not too bad. But if you've got a T9 in the eye, you have about 1.4 diopters of residual astigmatism, and patients aren't going to love that. So what we did with this patient is we brought him to astigmatismfix.com. There's other websites out there. Graham Barrett has one. Noel Alpins has one. They all do a nice job. There's 2 pieces of information that are critical. What's the refraction? And then which toric lens is it, and what's the axis of the rotation? So what we're really doing is we're calculating, when you know what the toric lens is and the axis of rotation, and you know the manifest refraction, you can subtract out the toric lens and now know the astigmatic aphakic state of the eye, and then you can calculate where you would rotate a toric lens to. And after you put in that information, the website will tell you where to rotate the toric lens to minimize the astigmatism. You can determine if that's a worthwhile solution. Couple of things to keep in mind. Look at the spherical equivalent. You can spin a toric lens all the way around in the eye without changing the spherical equivalent. So if you're not happy with the spherical equivalent, you're not going to get a good outcome. And then look and see how much residual astigmatism you expect to see and if that patient would be happy. So here's a patient of mine. You can see a little femtoarcuate there inferior or down and to the right, and you can see the toric lens actually rotated counterclockwise from where it was placed just a week before. So we go back to the operating room. We did an intraoperative aberrometry measurement. And what I like to do is, notice there's no 6 o'clock mark here. You don't need one. The toric marks are the mark inside the eye for the patient. And then you don't want to calculate what axis you're going to rotate it to. You want to calculate how far you're going to rotate it from where it is currently. And so in this case, we're going 30 degrees away from where the current lens is, or 28 degrees away from where the current lens is, something like that. Now, look how far away those 2 blue dots are. That's 3.5 diopters of astigmatism between those 2 little blue dots. And so when you're dealing with high-powered toric lenses, precise alignment is critical. This lens had only been in the eye for 1 week. And so I didn't need to put viscoelastic behind the lens. What I like to, if it's been in there longer, you may need to put viscoelastic behind the lens. I just opened up the capsule leaflets with a little viscoelastic. rotate the lens, in this case clockwise to the new alignment marks, remove the viscoelastic, and I did take a postoperative intraoperative aberrometry measurement. So prior to rotating the lens, the aberrometry showed 3.15 diopters, afterwards 0.43 diopters. Here's what the patient looked like pre-rotation and post-rotation. You can see the little dots down there a little bit on the right. And on day 1, she went from 3.5 diopters of astigmatism to 20 and less disappointed in me. So how do you do this step by step? The first thing that you do is measure a manifest refraction. It has to be a good manifest refraction because this is dictating your treatment. Measure the IOL axis and know its toricity. How do you do that? Use a slit lamp. Create a parallel pipette right on where those 3 dots are. Use a level app on whatever phone you have. Line that up with the edge of your phone and you know exactly which axis the lens is at. Plug in the information to astigmatismfix.com. Does it neutralize the astigmatism adequately? Does it address the spherical equivalent? Can I rotate this lens is a question. Did I have a broken bag or is it loose zonules or something? Mark the current axis, mark the ideal axis, loosen the IOL with viscoelastic, rotate it, and remove that viscoelastic. So what have we learned from Astigmatism Fix? Well, 76% of the time when there's residual astigmatism, it's because the axis that you chose was wrong. Where you planned to put it was wrong. 70% of the time, the IOL rotated. Well, how does that add up? Because 52% of the time, it's a combination of both. Interestingly, lenses have a tendency to rotate counterclockwise, especially the Technis material, not clockwise as we would have expected. We also found that the Acrosoft seems to be a little bit more stable in terms of rotational stability. This was confirmed by a study by Brian Lee and David Chang, although J&J is making modifications to its toric lens to improve stability. A lot of times these rotations are small, less than 10 degrees, but again, that can matter with higher powered toric lenses. And very interestingly, high myopes don't seem to rotate more, or at least we couldn't see that in our data, even though most people intrinsically would think that that'd be the case. So in summary, residual astigmatism occurs if you put the IOL in imprecisely, or if you put it in the wrong place, meaning you put it in inaccurately. The lens rotates. You can fix it by rotating the lens, exchanging the lens, doing laser vision correction, and LRI, or you can always use glasses or contact lenses. Thanks.
So John, let's say I don't have access to Astigmatism Fix, or it's just too much.
So you're not anywhere in the world?
Right.
Okay, got it.
So what's wrong with figuring out the axis of steepest corneal astigmatism postoperatively, and let's say we're measuring front and back surfaces, so we know the residual, we know what's left over, and just rotating the lens to that axis. Why do I have to use Astigmatism Fix?
Yeah, good question. So one misconception actually is that you can put a lens off axis and reduce the effectivity of the lens, but you can't. You always want to have a toric lens aligned in the steepest axis. So if you know what the true axis of astigmatism of the cornea is, you could do what you just said. That would be okay. But I bet it's easier to have a 4-opter and access to the World Wide Web than it is a device that'll measure anterior and posterior corneal astigmatism.
It's also nice to have some additional data, because when you're postoperative, you've taken out the lens, you have an implant, you get an additional piece of information, you should be able to get a better outcome using that information.
Yeah, and really the manifest refraction is just the summation of the anterior and posterior corneal curvature after you subtracted the toric IOL. So we're doing the same thing, you're just measuring it, with curvature measurements, and I'm measuring it with the manifest.
How much residual sphere would you leave in the eye? There's got to be, is it half a diopter?
Probably a half.
So half a diopter sphere error, you'll just rotate 0.75, you take out the lens.
Yeah, I think that in general that's true, and except for I wouldn't take out the lens, I'd probably do a LASIK enhancement.
Okay. And same thing, how much residual astigmatism are you looking for? Say half, or more tolerant there?
That's a little bit lower. It's if the patient is frustrated by it. So I'll do LASIK enhancements for +1/4, -1/2 after surgery, you know, in a multifocal, and I'll rotate a lens for, you know, 1/2 to 3/4 if I think that I can get them down to that almost zero residual astigmatism.
Do you think there is a more ideal time for when an IOL re-rotation should occur, like the shrink wrap effect that could potentially help
Yeah.
stabilize a bag? And two, is there anything else that you do use, like a capsular tension ring or anterior prolapse?
Yeah, good question. The ideal time to do it is debatable. If there's a rotation early, because most rotation occurs during the first day. So if, like this patient at a week, I know they rotated. It's not a healing issue. It's they rotated. So I want to get back in there and make this patient less mad at me sooner. Otherwise, I think any time within the first 6 months is pretty reasonable. If they're aggressively being fibrotic, I'd like to get in there sooner. The second question about anything that you do special the first time you rotate somebody, no. I did have one patient that I had to go back in and re-rotate, and I anterior prolapsed the lens. Perhaps putting a capsular tension ring in might help. Hard to really know if that's true or not.
I think one of the issues that involves in lens movement after surgery is the incision. So if the incision is not sealing well, there's hypotony. The eye's soft, so any kind of pressure from eye drops or eye rubbing could potentially rotate or reposition the lens.
So I have a question for the panel, because I hear this debated all the time. Is it leave it soft and it'll be more stable, or is it leave it firm and it'll be more
You should
stable?
leave it firm, but not have it in reverse pupillary block.
Okay, so how many people
I
say?
think it needs to be make a good incision that's not going to leak as number one. And then I like to leave it on the like physiologic plus side.
I say go soft, physiologic minus side. Well, because you want to see I like to see the posterior capsule kind of right around the optic.
So you want it soft?
I want it soft.
I think the incision is key, and some of the concern is if the eye's too soft, the incision can gape, and then you can see the lens rotate. So I think you've got to be really careful. Even
You want it firm?
Yes, firm.
I leave it a little soft, but I suture my wound.
Acute angle glaucoma.
Every toric gets a suture.
Every toric gets a suture. I take it out day one.
Wow.
Damn.
And your rotation rate.
Pretty low.
And your
All
rotation
his
rate.
Sam's
week
never seen
otherwise.
rotation.
What's a rotation?
Yeah, your rotation rate is.
What's a rotation? I don't even know what a rotation.
So you've never been on astigmatismfix.com. I mean, why even go there, right?
We record surgeons' names, so.
Thank you all for a very interesting discussion.